Good afternoon. Good afternoon, and welcome to Grand Rounds today. Please remember to fill out the attendance record, and also please remember to fill out the program evaluations. And if you could give us ideas in regards to future topics or future speakers, the CME committee would be very appreciative. Our speaker today is particularly well qualified to deliver our talk. Our speaker is Dr. Mary Marnach. She is board certified not only by the American Board of Obstetrics and Gynecology, but also by the North American Menopause Society. She is currently assistant professor of obstetrics and gynecology at the Mayo Clinic, and she has kindly accepted our invitation to drive down today and review menopause and hormone therapy in 2013. And please join me in welcoming Dr. Marnach.
Thank you very much. It's a pleasure to be here, and I appreciate that you asked me. And also, it was a lovely drive down now that spring has arrived. I think maybe summer arrived and we missed spring. Well, I don't have any financial disclosures. You will notice that I'm using a slide set from the North American Menopause Society. I am certified through them to be one of their menopause practitioners by taking an exam. I have high respect for NAMs. I think they are the leading experts in the world in women's health care. And almost yearly I go to their meetings, which involve at least 2,000 members and non-members. And again, it's always a pleasure to go and get updated. NAMS has asked us when we speak on menopause to use their slides because we're making sure we give you accurate and up-to-date information. And I'm probably like a lot of you, I love to have the AV people because I'm just not that good at that kind of thing. All right, there are a lot of slides to go through. I'm going to move rapidly, and all this is written down for you. I've taken some of the slides out just so I don't make this too long. We're going to speak briefly overview as far as menopause goes. We're going to review vasomotor symptoms and some of the major clinical issues that face women at this time. We're also at the end going to spend some time on the menopause hormone therapy statement from NAMS that was updated in 2012. I think it was the 7th time they updated it. So the definition of menopause, you know, it is the 1-year mark from her final menstrual period. It's represented by the permanent cessation of menses, and it's due to the loss of ovarian follicular function. It's a natural spontaneous sort of event, and the average age for a Caucasian woman to go through menopause in the United States is 51. Remember that certain ethnic backgrounds will go through menopause at an earlier age, but Caucasian women, it's around 51, knowing it's a spectrum. Some women will go through sooner, some women later. In the United States every day, and I find this an astounding number, 6,000 US women will reach menopause every single day. That's 2 million women per year, and that's because the baby boomers are of age. A woman's life expectancy, if she reaches 55 to 59, she likely will live to be in her early 80s. So we can plan to spend about 1/3 of our lifespan in menopause. That's why it behooves us to know how to care for these women. So how do women view menopause? That's a good question. There have been some surveys and studies done on this over the years, and for the most part, women expect to go through menopause. They regard it as a developmental stage or transition in their life. Of course, we see those women who have more trouble with it, but again, it's an expected event for many of us. And over 50% of women say they're more satisfied and happier as they age than when they were younger women. About 75% of women say they make some positive changes to their life as they transition through menopause. So what are the signs and symptoms? You know many of these as well because you see these patients just like I do. There's a change in the menstrual cycle. That usually happens in those 2 to 6 years of perimenopause before actual menopause. In the year or two before menopause, most women will tell you their periods space out by 2 to 3 months. Sometimes that's not the case, but that's very common. The vasomotor symptoms are very common: hot flashes and night sweats. Vulvovaginal symptoms like pain, irritation, dryness, very prevalent, and dyspareunia. And sleep disturbances are common, especially in women. The other symptoms you and I hear about are cognitive changes and certainly mood changes. I get women almost daily in the Gyn clinic where I work saying, you know what, my coworkers are noticing I'm changing, as is my partner. They say I'm a bit more crabby. I hear it all the time. There is no one universal menopausal syndrome that fits every single woman. I always tell my patients it's an individual, unique experience that will be yours alone. Natural menopause occurs spontaneously, but there are many women we induce menopause in. I've done my share of that by doing BSOs or bilateral self-phalangeal oophorectomies in women over the years for various reasons. Chemotherapy and pelvic radiation also induces earlier menopause. And then there's that subset of women who go into premature ovarian failure before age 40. That's about 1 in 100 women. And that can happen from an autoimmune issue, or we don't totally understand that. These women will have some intermittent ovarian function, but for the most part, they'll be amenorrheic. They will not have regular periods. Perimenopause, again, are those 2 to 6 years before menopause where cycles change in women and hot flashes begin. And it's often the most symptomatic phase for women. And oftentimes you'll see them in perimenopause before you see them in menopause with all of their symptoms. Let's talk about some of the clinical issues. Vasomotor symptoms, very common, 75 to 80% of women as they transition into menopause. These are those episodes of flushing accompanied by feelings of warmth and intense heat in the upper part of the body extending into the head. During the day, they're called hot flashes, and at night, night sweats or night flushes. They're related to small fluctuations in core body temperature superimposed on an extremely narrow thermoregulatory zone in the brain. And here's the anatomy of a hot flash. Core body temperature, skin blood flow, and heart rate increase. So she gets that intense feeling of warmth. When those things peak, what happens is she starts to sweat. And then she feels chills and shivering. You've all heard these women come in and say, yep, my nightgown's wet, the clothing's wet, and my partner wonders what in the heck is going on. Frequency, at least 75 to 80% of us have hot flashes as we transition through. Some women they're very significant in. Some women will tell you they only have a few. Other women all day long and during the night. The highest occurrence is in that late perimenopausal time to the first few years of menopause. After that, they tend to go away in most women. But I meet women like you do who have hot flashes to the end of their life. They may be more severe in smokers who tend to have earlier menopauses. Factors that contribute are a warm environment. It's why women my age dress in layers so they can remove things as they need to. Hot drinks, spicy foods, stress, anxiety, cigarette smoking, alcohol, all those things can factor in. Certain drugs that we put women on, certainly for chemoprotection today, or in somebody with breast cancer early on, 30s, 40s, we put them on tamoxifen, which is an estrogen receptor modulator. Those women tend to have more hot flashes. The tamoxifen doesn't help that issue. Also the drug raloxifene or Evista, used for bone protection, will create hot flashes. And I think the biggest culprit of all are the aromatase inhibitors. Excellent drugs to prevent recurrences of breast cancer, but unfortunately those women have a lot of vulvovaginal symptoms and a lot of hot flashes generally. I sometimes meet women that say they're going to stop those medicines because of the side effects, unfortunately. The SSRIs are actually used off-label for hot flashes, but in some women, they can be worsened by those drugs and the SNRIs. Disease conditions, these need to be excluded in women. Not all hot flashes are due to estrogen deficiency. Sometimes it's due to thyroid dysfunction, which is more common as we age as women, autoimmune conditions, infections, certain cancers. You need to rule those things out. It's why I love the internist at Mayo. They can tease some of this out when I'm not certain what's going on. And serum estrogen or estradiol levels may or may not help you. I don't use them a lot. I think sometimes We'll use those when we're not sure what's going on, and follicle-stimulating hormone levels or FSHs, but largely I don't use those. I go more by symptoms because there's so much fluctuation in those levels. I don't think they're that helpful. Treatment of hot flashes are based upon how severe they are for women, and I think that's who shows up in our offices. There's many government-approved formulations of hormone therapy today that can be very helpful, at least short-term, for these symptoms. There's a lot of other medicines out there that we use off-label, like the SSRIs, various dietary supplements, complementary and alternative options. And I'll just tell you in a nutshell, many of those things that women use over the counter, the soy products, the isoflavones, things like that, they may work short-term, but the literature would suggest they don't do much good. But that's what women are going out to buy if they choose not to come into you to review what's available prescription-wise. Sleeping issues. This affects both genders, but especially women. At least 50% of women from their 40s to their 60s say they don't sleep as well. And unfortunately, the next day they don't function as well, do they? Those of you in the audience that take call like I do, we don't function quite as well the next day when we're on call for 24 hours either, so we can understand this. And that's why women will show up and say, I just don't feel like I should. And so what can I do about it? Hormone therapy is really not approved for treating insomnia, but both oral and transdermal estrogen have been shown to help improve sleep overall and reduce hot flashes, especially night sweats. Micronized progesterone, and I use a lot of this in my patients. It's bioidentical. It's called Prometrium. I use that a lot, but I tell women, if you're on it, please take it at bedtime because it'll give you a dreamlike state. It's very helpful for sleep, but you don't want her to use it during the day and go to work. Cognitive changes. I bet you hear a lot about this, as I do. Some women will present in my office saying, something bad must be going on. I think I'm getting dementia. Well, there is evidence in the literature that psychomotor speed and to a lesser extent verbal memory decline in menopause, at least early on. And although depression and anxiety are related to cognitive decline, neither mood nor age account for these cognitive changes in this age group of women. And the good news is that these transient issues with cognition appear to improve somewhat in menopause as she gets further down the road. Potential stressors at midlife, many of you my age can relate to these things. Loss of fertility, sleep issues, of course, medical problems that start to come up, and changes in our relationships and in our careers. And then the empty nest where our children are moving out. I think they forgot to add, and then the nest fills up again because today's kids are coming back home with all the financial and economical problems in the world. And we are certainly the sandwich generation. I was just telling Stephen, I know this. Between taking care of kids and 6 siblings recently and my elderly mother, lots of issues. Mood disorders, loss of control, irritability, fatigue, mood changes at midlife may be caused by fluctuating hormones. That is now proven in the literature. But women with a history of more trouble in the past, like premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, may be more vulnerable to depressive symptoms as they go through menopause. The most predictive factor for depression at midlife and beyond is a prior history of clinical depression. I tell women there's a lot you can do for yourself, but you have to buy into it. And that means trying to find ways to relax. My patients often say, and so what do you do for that? And I just say, you know, as I age, I realize how important this is. And so you have to figure out what that is for each of you individually. I tell my patients, whether that's exercise, getting together more with friends, going to counseling, psychotherapy, meditation. I have a good friend who's a psychologist who's taught me meditation. I used to think it was all voodoo. I think it's very, very helpful. And then, of course, if women need them and a major issue is anxiety and depression, I think antidepressants are fine. The problem is they have some sexual side effects and other side effects, so you have to warn patients of that. Symptoms such as vaginal dryness, the vulvovaginal irritation, and dyspareunia happen to 10 to 40% of women at this time in life. In my office, it seems like 80%, but the literature would say 10 to 40%. And unlike hot flashes or vasomotor symptoms, these don't go away with time. A lot of times women need treatment lifelong for these issues. And treatments do include regular sexual activity, lubricants, moisturizers, and local vaginal estrogen, especially if she doesn't need something for hot flashes. The least we can do is treat the vagina if she's willing to do that. This is what happens. The cartoon on my side shows a nice rugated, those nice folds in the vagina that we see in women. Those of you who do women's health see this. The secretions look normal, the vagina looks really nice. When we get into menopause, the tissue's thin, they become less pliable, those rugated folds go away, and the vagina just doesn't look as healthy, does it? The pH goes up to around 5 to 5.5, and unfortunately that makes her more prone to infection, including yeast. The cervix too, those of you who see a lot of women in menopause like I do, you notice that it becomes flush with the upper vagina. It's much harder to do endometrial sampling and that sort of thing in these women with time. So the woman in the middle is in her 60s, and she's had estrogen on board. Look at her vulva and her introitus. They look very healthy, and I'll often say to my patients, well, you might be 60, but you have the vagina and vulva of a 30-year-old. Good for you. The woman on the very far side is a woman same age, no estrogen. We see women like this every day in our offices, don't we? And while I respect not taking estrogen if she really doesn't want to use any, a small amount can make a huge difference. Some of the non-hormonal treatments for vaginal atrophy, these things don't work wonderfully, but they help some, especially in a new breast cancer diagnosed patient. I'll tell them to go get a product like Replens over the counter. It's a bioadhesive polymer, and it releases water and holds it against the vaginal walls. She needs to replace it about every 3 days, and most women all say the same thing. Well, these are helpful, but they're messy. I couldn't agree more. Lubricants, and not all lubricants over the counter are created equal. I don't know, my husband says it's weird, but I think I'm an expert at lubricants. The ones I like are in the second bullet there, the water-based without glycerin. Believe it or not, when you look at the back of a lubricant, they've got all kinds of things in them, and some women notice that they're sort of allergic to some of those things. The problem with glycerin in a postmenopausal vagina that has no estrogen effect, glycerin breaks down to sugar with that high pH that she's got, and they will get more yeast infections, and a lot of women don't know that. The other kind I like are the silicone-based. KY makes a product called Intrigue. They're very slippery. That way they're very nice, but they're hard to clean up, and oh my, if she spills them on a tile floor, I have heard stories you would not believe. The other thing is that if her partner has any erectile dysfunction, the silicone-based lubricants are really, really not very helpful. And I tell women, you can just go on drugstore.com and really look up these lubricants very easily. It's like Walgreens on the internet, and find lubricants that work better for you or might work better, and you can read the ingredients in each one of them. Hormonal treatment of vaginal atrophy, this works the best. It's been proven to restore vaginal blood flow, decrease the vaginal pH to around 4, like a younger woman, and improve the thickness, the elasticity, and the pliability of the vagina. So if she doesn't need treatment for her hot flashes or osteoporosis prevention, she can just use a local or vaginal estrogen. And here they are. I've slipped this slide in for the reason that I continue to see this at Mayo. I see many women walk in my office who are using the entire applicator of the estrase or Premarin cream. And I'm here to tell you, based on the literature, you only need a small amount. It always strikes fear in my office when I see a 70-year-old, like I did the other day, who came in with spotting out of the blue. She did have an estrogen dependent cancer. And again, it's very important they're using very, very small amounts. These amounts are the ones touted in the literature to be effective, used twice a week. I like East Ring. It's a ring, but it's not very pliable. It's not like the Nuva ring you'd use for contraception in a younger woman. And I have trouble with the insurance companies covering East Ring in the Rochester area. NAMS has said too, if you're using very low doses of estrogen in women, you don't need to use a progestin or a progestogen to protect the uterine lining. You do, however, if she's on systemic estrogen. Then she should be on both estrogen and a progestogen, so she doesn't develop an endometrial cancer. I use a lot of dilators in patients. They can Google these. We have a set at Mayo we give away free that are acrylic. I like the pliable ones. Some of those are pictured here. Women can get these very easily on the web, and they're really for women who have been widowed for a while, no partner, and then they find a new partner. I think they're very helpful before she delves right into sexual activity. Urinary complaints, again, very common in women in this age range. The most common one is stress urinary incontinence. And unfortunately, the literature says that estrogen does not help stress urinary incontinence. It might help urge incontinence a little bit. It does help urgency, overactive bladder, and it helps those women who have frequent urinary infections. I think it's very important in this age group, though, if she comes in telling you she has hematuria, you need to make sure that you don't have an issue like an underlying malignancy. Also infections. I think a lot of women walk around low-grade infections and we don't have those treated either. So again, the idea would be to use low doses to help these issues like overactive bladder, the urgency, and the symptoms of vulvovaginal atrophy. Again, it will not work, or you should not tell women that it'll work for stress urinary incontinence because the literature does not support that. Sexual health. Well, here's a really big black box, right? If you ask about her sexual function, and I think we should, I don't think we do enough of that. I don't do enough of that. I was part of a group at Mayo that set up a clinic specifically for sexual medicine in women. It was great. We had hour-long appointments. I worked with internists and a sex therapist, and it was a great clinic. But in my gyne clinic, I rarely have time to delve into this unless she's specifically seeing me for it. But I will tell you, if you let women talk, and you know this too, they will tell you that everything has changed. A peak time for sexual dysfunction to be talked about is our 40s to 60s as women. And women will tell you, my libido is less, my arousal, orgasmic function, and the pain issues. And they are right. In most women, those are more prevalent as they age. And I just tell women, you're right. That's exactly what happens as women age. We know that estradiol really decreases at the time of menopause, but androgens in women actually just decrease slightly at menopause. The biggest drop for our androgens to fall, and women do make androgens in the form of testosterone and DHEA. Their ovaries make that, their adrenal glands, and their peripheral cells. The biggest drop is from our 20s to our 40s. Just a small drop, though, at menopause. Rosemary Bashan is considered an international expert in women's health, and I think she pegs it well here. When you're talking with women about their sexual function, everything factors in, from her overall physical health to her emotional health, to her experiences in the past, to her partner relationship. It's very hard to fix sexual dysfunction in a woman who's not doing very well with her partner, is it? But all of that factors in, and that's why I think it takes a village to treat these women well with their sexual issues. Again, if you give her systemic estrogen or vaginal estrogen, you might improve things slightly, though, with her sexual health. In fact, you might improve them quite a lot because she's sleeping better, doesn't have hot flashes, her vagina feels better. She might be inclined to be more sexually active. So in some ways, it does seem to help. But it is not touted by the literature to be the sole therapy for sexual dysfunction. What about testosterone? Testosterone is a lecture in itself. I've given lectures on testosterone. The woman in the world who's done the most research is Susan Davis. She's in Australia. It's fun to hear her talk at NAMS. And she is right. The literature does say that testosterone therapy for women in midlife may improve sexual desire, arousal, orgasmic function, help lower pain, might improve bone density, well-being, fatigue levels, and all of that. But in the United States, there is no testosterone therapy that's approved for these purposes. There is a patch in Europe called Intrinsa, and there is a product being looked at by the Bioidentical company called Livigel, but it is not yet approved to go onto the market. Osteoporosis is the last clinical issue we're going to touch on. Very common problem, especially in women. About 10 million Americans, maybe more, have osteoporosis, and 8 million of those at least are women. And unfortunately, hip fracture rates increase in women every 5 to 6 years into menopause. So what can women do? Well, I think first of all, as medical providers, it's important to get bone densitometry by the 60s. NAMS at their last meeting said, maybe all this bone densitometry testing we do in the 50s isn't all that helpful because we see a lot of women with a little bit of thinning, the osteopenia. But I do think it's important to test those women who are at high risk with certain chronic medical conditions, a long time use of steroids, that kind of thing. But otherwise, I don't test women much before their 60s. I do think it's important to tell women, you need to look at your lifestyle. Are you doing weight-bearing exercise? Have you cut back on your alcohol and tobacco use? And please use 1,200 milligrams of calcium a day. The United States Preventative Task Force just had a statement that women only probably need 1,000. They also said that they thought vitamin D, 400 international units a day was probably enough. NAMS says 600 to 800. And we all know that we use more in those women that we can show a deficiency in for vitamin D. Now we're going to lapse into the menopause hormone statement by NAMS. These are the slides that were reviewed at the recent NAMS meeting. Marjorie Gass, one of their executive members, stood up and gave these, and she said, this is where we are today based on the literature. First of all, I just want to mention, do not forget in your perimenopausal women that they still need contraception. I use a lot of low-dose oral contraceptives in this age group. I will tell you I like Mirena IUDs a lot too. But if I have a woman with irregular cycles, pelvic pain, heavy bleeding, I like the low-dose oral contraceptives. If she's a non-smoker, she doesn't have migraines, and she's healthy enough to take them. I still continue to see women in their 40s who have unintended pregnancies, like 50% of us in the United States. So I just think it's important to not forget contraception in this age group. There are certain women you do not want to use oral contraceptives in, though, for reasons like hypertension that's uncontrolled, obesity, or those women with a clotting disorder, so you need to be careful with what you use. And when do you stop oral contraceptives? I think we all wonder that. I usually stop them in the early 50s, and if she's very worried about hot flashes, I'll go ahead and transition her right onto hormone therapy. Sometimes I'll just say, though, do you want to see what happens over the next 4 to 6 months, and I'll see you back. I often do it that way because women aren't always sure they want to take hormone therapy based on all the media attention they've gotten in the last several years. Remember that a birth control pill, even low dose, is about 4 to 6 times the amount that's in hormone therapy. And I continue to tell my patients, let's only give you what you need to control your symptoms. So here we go with the position statement. We're going to do a little terminology first, and then I can just refer to estrogen therapy as ET. Unopposed estrogen is prescribed both systemically for women who don't have a uterus and locally just to the vagina for those women with mainly vaginal symptoms. EPT is estrogen progestogen therapy. The progesterone should be added to those women who have a uterus. I almost have no patients in my practice with a uterus that I don't use some form of progesterone. And the progesterone is not always tolerated very well, but we work really hard to find one that will work for them. I still have women every year that quit the progesterone. I see them and they have complex hyperplasia with atypia, and now we're talking hysterectomy. I also have those women that show up with uterine cancers because they've chosen to stop the progesterone when they know I said they shouldn't. Bioidentical hormone therapy, a lot of data on this in the last few years in the media due to certain folks in this country who are spokespeople, they think, that know a lot about these. But the truth is this by NAMS. These are the hormones chemically identical or very similar to those made in the body. They're available in 2 sources, the FDA-approved and tested, like the Vivel Dot, the Climera patch. I tell my patients those are things that are bioidentical and they're FDA-approved. Estrace is another one used orally. The unapproved and untested from compounding pharmacies, NAMS does not recommend those for obvious reasons. We just don't know from batch to batch if they're mixed up the same, if they're pure. And these companies have made, I really think, false pretenses and told women that these compounds are safer without data. We have to assume whether compounding pharmacies make them or we prescribe them that they carry some risk. All oral estrogens, most transdermal, and one vaginal estrogen, that would be Femring, are approved for moderate to severe vasomotor symptoms. Some oral and transdermal products are approved for the prevention of osteoporosis, but not the treatment. NAMS makes that very clear, prevention only, not for treatment when you've diagnosed osteoporosis. Then other things should be used, like the biphosphonates. Local vaginal estrogen is FDA approved for the atrophic vaginitis symptoms. And the product at the bottom there, one vaginal product is indicated for urinary urgency and dysuria, that's E-string. Since the WHI, the Women's Health Initiative, was first published, the first arm of their hormonal group. And remember, in the Women's Health Initiative, or the WHI, there were 27,000 women involved in those hormonal arms. So they published in 2002 on the EPT arm, that was Prempro, and on 2004 on the estrogen arm, that was Premarin. Both trials were stopped early because some things came out, and this hit the media. And so now any estrogen-containing product has to carry, based on the FDA, warnings for possible risk as far as cardiovascular disorders, endometrial cancer, breast cancer, and possible dementia. Although only 2 products were studied in the WHI, all HT products, including natural bioidentical and compounded hormones, are assumed to have similar risk until proven otherwise. Will there ever be a huge study on Vivel-Dot or Estroderm or Climera? The Coronis or Keeps trial in Mayo was one of the sites for that, only had 725 women. That wasn't a big trial, but it was still expensive. I think it was 15 million. The WHI was many, many hundreds of millions. And so we just won't have a big trial again like that because it's too expensive. So again, ET, with or without progestogen, is the most effective treatment of menopause-related hot flashes or vasomotor symptoms. And almost all of these products are approved by the government for that. Vaginal treatment also approved. And what about sexual function? You heard me say that she might improve sexually when she uses hormone therapy, but again, it is not recommended as the sole treatment for other sexual problems like diminished libido, arousal, and orgasmic dysfunction. We all would like a product that's available for that. And the experts in this area, in this country, and around the world say we need something. There's a lot of research going on, but we're just not there yet. Urinary tract health, again, remember that hormone therapy will help things. Overactive bladder, urgency, maybe urge incontinence, but not stress incontinence. And it will certainly help those women somewhat, usually if they have recurrent urinary infections. I tell my patients I can't promise you that, but hopefully they'll help. What about quality of life? Although hormone therapy is not approved for enhancing quality of life, it can improve health-related quality of life in women who are symptomatic. It's unclear if it helps those women who are asymptomatic, and again, those women aren't likely to show up in your office. Osteoporosis. Hormone therapy reduced fracture risk in postmenopausal women in the WHI. So now there are many products approved for preventing osteoporosis, but again, not for treating it. Extended use of hormone therapy is an option for those women at high risk for osteoporotic fracture when alternative therapies won't work or she can't take those. We all know today that the biphosphonates are a little scary to women because of the jaw necrosis issues, even though that's a very small grouping of women that will sustain those from biphosphonates. But again, women get a hold of this data in the media. Risk of long-term hormone therapy use should be considered in those women at high risk for osteoporosis. Benefits of HT on bone mass unfortunately dissipate quickly after she discontinues the hormone therapy. And what about coronary disease? The reason this loomed out in the EPT arm of the WHI is that 1 woman in 1,000 would have a coronary event that we could link to her hormone therapy. That made huge media attention. 1 woman in 1,000. Wolf Udian, who was a leader of NAMS for many years, stood up at the last meeting and said, why don't we turn it around and tell women that 999 of them will not develop a coronary issue, very likely from their hormone therapy. We're just not there yet. What did come out of the estrogen arm of the WHI is that those women from 50 to 59, and actually was shown in the EPT arm too, according to what I can figure out in the data, but those women 50 to 59 actually had a reduced number of coronary events and coronary artery calcification. So therefore, in younger women, it may help. But again, HT is not currently recommended for coronary protection in women of any age. I still remember as a resident in the 90s at Mayo how we would hand scripts for hormone therapy to 80-year-olds and tell them, look, you should take this so you don't get a coronary event. We're just not there anymore. And what about stroke? Both ET and EPT appear to increase ischemic stroke. Again, that was about 1 in 1,000 women per year in the WHI. They have no effect on hemorrhagic stroke. Women who reach menopause, though, remember, are more at risk for stroke than younger women. It just is what it is, whether they take hormones or not. And what about venous thromboembolism? This is the thing that loomed out the most in the WHI. I believe it was the EPT arm that 10 to 18 women per 1,000 would develop a blood clot yearly from their hormone use. And so we know that, and again, that was oral hormone therapy. We know that risk emerges in the first 1 or 2 years after she starts the hormones. That risk seems to be lower the further she gets down the road with use of hormone therapy. There's possibly a lower risk of blood clotting with the transdermal approaches or something on the skin, but there's no randomized controlled trials that say that. That's just based on observational studies. So today, when I start somebody on hormone therapy, I aim for the transdermal like I use. I tell women it just may be better from a blood clotting standpoint. I never put a woman who's had a PE history on estrogen therapy, even if she's anticoagulated. I just don't do it. Now, if she's had a DVT in her lower extremity, maybe from bed rest, or she's heterozygous for factor V Leiden and she's never clotted, those women I'm okay with it, but I tell them there may be some risk. Nothing is without a risk. And what about endometrial cancer? HT is not recommended if you have a history of this. I have a couple women in my practice with early stage endometrial cancers who, once we treated them with hysterectomy, I and their oncologist have told them they can use estrogen therapy, but I use the smallest amount, and I tell her that is not without risk. Generally, though, it is not recommended if she's got an endometrial cancer history, and most of my patients wouldn't take it anyway with that kind of history. Remember, again, if she's got a uterus, you need to use a progestogen if you're using estrogen. How do I use that? I'm just going to make that clear right now. I use it for 10 days. Rogerio Lobo from Columbia, New York, I heard him lecture one time, excellent lecture on progestogen agents, and he said you need to use it at least 10 days. Some of us use it 10 days or 12 days a month, so we'll use it kind of sequential versus using it every single day. NAM says we don't really know if there's better protection as far as the breast with using it either way. The problem is in that EPT arm of the WHI, there was an increase in breast cancer. We're about to get to this. It was 1 woman per 1,000. And anyway, there is some risk there. It didn't show up in the estrogen therapy alone arm, which was interesting. But I think the point of this slide, if I've driven it home, is use a progesterone if you're using estrogen. Some of us at Mayo will even use the progesterone only every other month or so. It makes me nervous to only use it every 3 months, unless I'm using a very low amount of systemic estrogen. The experts in the field would say you should use it monthly for at least 10 days. So here we go with breast cancer. We're getting towards the end, thank goodness. The diagnosis of breast cancer increased with the EPT use in the WHI. It started at 3 to 5 years and beyond. In those first few years, it didn't seem to be an increased risk. It was 1 woman per 1,000 per year. It's unclear whether EPT risk differs between continuous and sequential progestogen. But again, most of us believe the progesterone must play some part because it was the EPT arm that had more breast cancer. The ET arm did not. We know that estrogen does increase breast proliferation. It makes the breast look more dense on mammography. And density, as many of you know today, is a risk factor for breast cancer. And the risk of a new breast cancer diagnosis declined 3 years post-EPT cessation. So when they stopped it, new diagnoses of breast cancer went down. Breast cancer mortality was higher in women assigned to EPT than in those assigned to placebo. Women starting EPT shortly after menopause experienced an increase in breast cancer versus those women in the EPT arm that didn't start it for 5 years from their menopause. Then there wasn't an increased risk. Very interesting finding, and I can't explain that. The ET arm again showed a significantly decreased risk, believe it or not, of breast cancer. Initially, the researchers from the WHI said it wasn't statistically significant, so they didn't tout that one very much. But again, the estrogen-only arm did not show an increase in breast cancer. And ET and EPT use in breast cancer survivors may increase recurrence risk, so most of us will not use estrogen therapy in women with a history of breast cancer. Our breast clinic at Mayo has a few women on estrogen therapy after their breast cancer, but it's very few women, and they're so symptomatic, that's why they use it. What about ovarian cancer risk? There were increases of ovarian cancer in those using EPT in the WHI, but the numbers didn't reach statistical significance. And after breast cancer, it's ovarian cancer that all women worry about because it's so deadly. What about mood and depression? The evidence is mixed here. There is evidence that HT should not be recommended as an antidepressant, but again, it may help moods. But I tell women, if your major issue is anxiety and depression, we should treat that instead appropriately, rather than just saying estrogen's gonna do the trick. What about cognitive changes, and does it help for that? Well, in the WHI memory study, there was an increase in dementia, unfortunately, in those women 65 to 79. The WHI included women from 50 to 79, not beyond that. That was kind of a blow, and I've often wondered, is it because she's got some calcification in her vessels already? And that's why we saw that. Again, you cannot tell women that it's recommended to prevent dementia. I have women ask about that regularly. And what about those women who go through menopause early or have premature ovarian failure, or somebody like me takes their ovaries out at 35 because of endometriosis? What should you do with them with estrogen? Well, if we're taking the ovaries for a cancer, estrogen's not the best idea. But if we're taking them out because she's a BRCA carrier or for some other reason, it is a good idea to replace her to age 50. Because BRCA 1 and 2 are in the media due to an actress in this country who just had a double mastectomy, she hasn't gone there about her ovarian function yet. But at Mayo, those women with BRCA 1 and 2 that we take the ovaries out, we do replace estrogen to the age of 50, and then beyond that, we stop it because nobody has the data. Progestogen, again, should be used for women with an intact uterus. And you have to play with the progestogen in women. A lot of women don't tolerate progesterone very well. They'll tell you they get headaches, side effects of all kinds, bloating, moodiness, all of that. It's why some of these women I'll put a Mirena IUD in so I can get around using it orally. Transdermal progesterone is absorbed erratically in women and is not shown to be protective for the uterus. Vaginal progesterone might be, but it's very, very expensive. And I should mention, maybe you know this, but the Mirena company has come out with a newer low-dose levonorgestrel IUD that might be very good in teenagers and these women, called Skyla. Bioidentical hormones, again, many well-tested government-approved hormone therapy products contain bioidentical hormones. Those that are compounded in pharmacies, though, they just aren't well tested. So those claims by actresses in this country and other folks have to be taken very carefully. Duration of use. I'm going to skip this part and just go to the summary. You can read those. That's all in your syllabus. Again, I think hormone therapy has a part or a place for certain women. I think we're at some negligence if we don't at least talk to women about it in their 50s. I think it can be of great benefit. The biggest problem is we don't know how long to use it. So I get women on it 5 to 7 years, and they say, now what, Dr. Marnach? And I say, I don't know. Let's talk about it. I often lower the dose. If she's still on it in her 60s, I lower it a lot. My department chair the other day and I talked about this. She said, what are you going to do? She's a gynec surgeon. She said, I'm probably going to quit it. I said, I'm not so sure, but I'd use a very low dose as I get into my 60s because, again, we just don't have the data for how long anybody should continue it. And there is some risk, again, with breast cancer, especially if you have to be on both estrogen and progestogen. Alternatives, just want to mention these briefly. There's a lot of not FDA-approved indications or drugs that you can use for hot flashes. And even though in some women the SSRIs might make their hot flashes worse, in many women they're helpful. So I've been known to use Prozac, Paxil. The one I like a lot is venlafaxine or Effixor. It's 75 milligrams at bedtime can be pretty effective. It's not as effective as estrogen though. And a new one showing up in the NAMS literature in their Menopause magazine, it's called Menopause, is Cymbalta being used for hot flashes. So any of these seem to have some effect. The other thing I use a fair bit is gabapentin, especially at bedtime. Charles Loprinzi, one of our oncologists at Mayo, he's actually done a study. Guess how much gabapentin it takes to equal estrogen to help hot flashes? A really big dose, 2,400 milligrams a day. That's a lot of gabapentin, and a lot of women would not tolerate the side effects. I have women with pelvic pain and chronic vulvodynia that I put on those kind of doses, but it's not tolerated so well. And then what about all these things over the counter that women use? Again, the meta-analysis on these products would say if they have any effect, it's temporary. Long-term, they do not show the efficacy in treating hot flashes that estrogen does. There are other things in your handouts, your syllabus there, and I'm not going to cover those, but those are in there. Thank you very much. That was a really long lecture. Thank you very much. I'm happy to answer questions as best I can.
Thank you for the excellent lecture. I was a little concerned about the the anecdotal experience you presented about the woman bleeding from the use of estrogens topically. And I see that in your slide you have that you do not advise that, basically because it's not FDA approved, right, for that indication.
Right. Well, the thing about that is once in a while, I think I've seen it 3 times in 18 years of practice. I was an NP and PA before I went to medical school, so I guess I've got a whole lot of experience, but I have seen what I thought was an estrogen-dependent cancer in women who were using high doses of estrase or Premarin vaginally. They were using the entire applicator. That's why my point is to use a very small amount. I'm not certain that I've ever seen an estrogen-dependent cancer in the uterus if she's using that small amount twice a week, like Vagifem 10 micrograms, as you know, that's been decreased from 25 to 10, or an eighth of the applicator of estrase, which is still 50 micrograms, or a fourth of the Premarin applicator. In fact, I have a lot of patients that don't even use the applicator. They just put a small amount on their finger and put it intravaginally and around the urethra, because that's another area that tends to be very affected in these women. So I do have a couple patients who have had early stage, not aggressive uterine cancers that I'm using some estrogen in systemically, but they are on the lowest dose I can give them. And I tell them it's not without risk.
Sure. Thank you.
You might wonder too, what do you start a woman at 50 on as far as a patch? I usually use the 0.05 Climera patch or the Vival Dot 0.05, and then I'll play with the dosage a little. If she's younger in her 40s, I might use the 0.075 or the 0.1, but I tell women, let's not use more than you need because these hormones maybe do have some risk based on the literature. I think it's low risk, but I think it's not zero.
I know this is a different, I see a lot of men as an internist. I had a patient who had prostate cancer and then androgen deprivation therapy. and he's having the same hot flashes at night, and just like women do. Is that something you've seen in the practice? I mean, not, but have you heard talks like that? I mean, is hormone therapy with estrogens something beneficial in these people, in men with hot flashes and stuff?
Yeah. And I can defer that one because I don't treat men. You know, I have heard of that, and I don't know what they do about it. I would think you could try an SSRI. The other thing I didn't mention about SSRIs, and I'm sure you all know this, but I think it's important to mention to patients, 30 to 60% of men and women you put those on will tell you it's harder to achieve orgasm, their arousal's more difficult. And so remember, a drug we might use for one thing might affect something else. And I just think patient information is key. So they don't come back and they're mad at you for doing that. But I don't know how to treat a man with a history of prostate cancer, but I know a lot of people at Mayo that could help you in your urology. We do a lot of surgery for prostate cancer, obviously, there. Again, the point about the progesterone, I use it for 10 days a month. She'll withdraw bleed after in early menopause. What happens is she gets further down the road, she probably won't bleed on it. I had an internist ask me a year ago at Mayo, so if she stops bleeding on the progesterone, still has her uterus, can I stop the progesterone? I go, oh, that would be a really bad idea. You need to keep it going even if she doesn't bleed on it. I don't use much progesterone on a daily basis, but I have some women that like it daily. And the people who compound it say she should have estrogen and progesterone every day. I tend to use it sequentially, so for 10 or 12 days a month or every other month. But I don't like to go less than that. 1 year in my practice, I had 4 endometrial cancers or hyperplasia where we had to operate on them. And they were all women that stopped their progesterone.
Do you usually prefer tapering down or abrupt stopping?
That's a good question. That was on one of the slides. NAM says you don't need to taper, but a lot of women feel better if you do. Instead of their Vivel dot twice a week, they'll go to once a week for a few weeks and then just stop it. It is true, some women will have rebound hot flashes, but remember again, hot flashes are usually those first few years of menopause. Most women coming off in their 60s or late 50s won't have a lot of symptoms, but if they do, I'll say, so what do you want to do? Go back on or use an SSRI? You know, I work with them. I rarely stop something and just say, hey, call me if you need to. I usually see them back in 6 months because I want to see how they're doing. That's a tough thing, as you know, to get patients back in. Yes.
Who is managing their symptoms, their vasomotor symptoms? They're there, but they're not complaining significantly about them. They do have stress incontinence or urge incontinence. I guess what's the balance of, if they're willing to kind of live with the symptomology of no hormone therapy, do you really encourage a hormone therapy? And what are the risks of endometrial, cancer or endometriosis without any therapy?
Well, remember again, hormone therapy won't help stress incontinence. It might help the urge, the urgency, urge incontinence, or like the repetitive bladder infections. I'm the first one to tell my patients, I respect your opinion. I am not going to give you hormones if you won't take them. We know when we used to prescribe them, half the scripts got thrown in the garbage and never filled anyway. I'm not sure what the stats are today, but I tell women, first of all, I respect your opinion. And you know what? From NAMS, you can get a wonderful booklet on hormone therapy, all the different kinds, the symptomatology, it goes through all that. I hand that to her and I say, why don't you think about it? And then come back to me in 4 to 6 months and we'll talk about it. A lot of stress incontinence today responds very nicely to the slings that are done by urogynecology and my colleagues that are urogynecologists. So if she has much of an issue, I'll send her through our urogynecology clinic. We're very niche practiced at Mayo. I'm a general OBGYN. I don't see and do all the surgeries anymore. I do obstetrical surgery though, but yeah, I tend to send women where they need to be. And I make sure with bladder symptoms she doesn't have an infection. And if you see hematuria, oh my God, you want to work that up, right? Because you still see bladder cancers and renal cancers in these women on occasion. So again, I highly respect the patient's opinion. I just think we must. But I also think part of that is educating her so she can make an informed decision. Because the media has not helped us. They've gotten a hold of some of these very, well, they are true statistics, but they've blown them out of proportion. I think it's why, one of my colleagues said it yesterday too at work, she said, how many women do you even put on it anymore? They're hardly showing up. Well, I run sort of a menopause clinic out of our outpatient clinic, so I still see a fair number. But I think she's right. Not as many are showing up. I think women are just living with it. They're sucking it up. But I think we have some duty to tell them that they might be beneficial short term and they don't have to live with all these symptoms. We can help. Thank you again very much.